Don't talk bad about anybody. Share my screen. So chapter 14, one of the longest chapters, or the longest chapter in the book. Who's all done? Who all is done with chapter 14? Good students. We have some good students in here, and then some not good students.
Hey, I did good catching up on stuff.
You finished chapter 14 yet? So, here is my opinion of the information that's in 14. It may be the longest chapter, and it's a very important chapter, but it is not a hard chapter. But it is hard. It is important that you guys go through it and understand what you're doing in the secondary assessment. So on your medical patients, it's a detailed focus, right? So they're complaining of chest pain, so you're gonna kind of gear your assessment towards chest pain. They go over some sample and OPQST questions, which is very important you guys get down because it's kind of a basis of your whole secondary assessment whenever you get into it. The second part of the secondary assessment will be in a lab form. Where we add that to, we've already done the scene survey, the primary assessment, where we go and do the ABCs, determine their level of consciousness, and determine their transport priority. And then after that, at that point, we go into the secondary assessment if possible. And all your patients, if you do these skills checks on, you will go into your secondary assessment. You guys can shut that door if you want, because they're going to be yapping on the scanner. They always forget that they have TAC channels they can go over to, so then they just take over our channel. Anyway, we'll get started. There's 164 slides, so there's quite a few slides. There are some videos.
Techniques used during the physical examination include inspection, palpation, auscultation, and percussion. Inspection. Palpation. Auscultation. Percussion.
I'm going to be honest with you, I've never used percussion in EMS. Yeah. Go back. What did you do? We're already on slide 59. Yeah.
Okay.
Guess we don't watch these videos. They're just there for us to watch in the future. They take us all the way up later to the slides. So. Topics is a secondary assessment, body system examination, secondary assessment of the medical patient, secondary assessment of the trauma patient, and detailed physical exam. Your medical patients are going to be I think they're going to be your more difficult patients. Or they can be. It's the patients that you might not be able to figure out front. Trauma's pretty easy, right? You know, they're broken bones or bleeding or whatever. We know what happened usually on a trauma patient. Yeah, sometimes we got to figure out, how bad it is. But we typically know what happened. So. Reassessment and then critical thinking and decision making. So the secondary assessment, components of the secondary assessment. The physical examination, the patient history, your history of the present illness, past medical history, or PMH, and then vital signs. On past medical history, whenever you're getting a past medical history, for EMS wise, sometimes it's very important to say, do you have any past medical history related to this or any pertinent? You're looking for pertinent past medical history versus, well, I broke my arm whenever I was 12, and they'll go on and on, which might be important to be in their records or whatever. But for us dealing with chest pain, it's really not important that we know if they broke their arm. So, and then vital signs. A sign is something that you can see. So, do I agree with that? Yeah. But can I? Yeah. Can I see a pulse? And that is a vital sign. But anyway, a sign is something that you can see. So a sign would be they're vomiting. They have bruising around their eyes. Those are signs. Symptoms, something your patient tells you. I'm nauseated. I have chest pain. So kind of try to keep those, separate, and they'll help you on your charting whenever you guys get to chapter 16. Reassessment is a continual process. We've talked about this several times where you're going to do something or treat your patient, and you're going to reassess to see if it helped them, see if they're improving, if they're getting worse. They also have, when you're doing your reassessment, you start developing trending patterns. So if our pulse continues to go up and our blood pressure is going down, there's a good chance we're going into shock, right? We're compensating, but now we're starting to decompensate, and then all of a sudden our pulse is going to start coming down and our blood pressure is going to keep coming down. And so we could trend that out over time. History taking techniques. Ask open-ended questions. Not does it hurt here? Describe the pain? What does the pain feel like? Let them answer it with an open-ended question. Sometimes you got to be careful with the open-ended questions. Use mnemonics, and these two mnemonics have been around EMS for a very long time, and it's sample and OPQRST history. Something that I had to memorize when I was going through my basic class. Sample is signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to what's going on. OPQRST is onset, so the onset of whatever's going on, provocation, so does anything make it worse? Quality, radiation, where does it go? And severity, so and then time, and how long has it been going on. So physical examination techniques, observe, we just watched a little video. Look, use your eyes to look at the patient, observe them. A lot of times when you walk in and you through observation, you're going to just look and see that they appear sick with your observation. Ellen, were you saying also the touch and feel? So see how that skin feels. Auscultate. You're going to listen. Use your stethoscope and listen to breath sounds. Nurses like listening to bowel sounds. Not something that EMS has really got into.
I don't like it.
Sabrina listens to them.
It's a good thing.
It is a good thing. And it's a good thing if you know what you're listening for. I think maybe with EMS, we don't do it because we were never really taught what we're even listening for. Well, that's a good thing. Bad thing. A bad thing would be you didn't hear that. That'd be a bad thing. But anyway, then palpate, and we do palpate things such as when we do a head to toe, the head, the neck, we palpate everything. And then, palpate the quadrants of the abdomen and things like that. So one of the hardest things for me whenever I was going through my paramedic training was hands-on to actually touch my patients. It was always, just always something I was okay at a distance, but it's something that some people have to learn, to just really, be touching your patients and stuff. I didn't do it much. And
you can tell, almost an assessment by
just by touch. Yep, just by touch. Another thing that touch does, and maybe not the palpation part of it, but a touch does, a sincere, pat on the shoulder, on the arm or whatever, comforts your patient. Anyway, I wasn't the best person at palpation or touching the patient. So observe the patient for an overall sense in his condition. Like I said, a lot of times when you walk in, it's almost instant. Oh, this isn't good at all. Or, why are we even called here? Or that person's dead, and they've been dead. Body system examinations. Respiratory system. The most important determination when assessing the respiratory system is whether the patient is breathing adequately. See if they go further into that. Obtain history of existing respiratory conditions and medications taken for each. Determine if medications have been taken as prescribed. Determine if signs and symptoms of the episode match the previous episode. Hide this. Let me go back one slide. So what are some signs that we will see? What are some signs of a patient not breathing adequately? Remember what the term signs is. What are some signs of the patient? See a rapid. Okay. So there we go. We had several there. So we had rapid movement of the chest, a cyanosis around the lips. Yeah, so those are signs. Good job. Things that you could observe or look at. Right? What are some symptoms? Yeah, so they're telling you that they're having trouble breathing. So, all right. Choking.
That could be.
Yeah.
Is that a symptom or a sign?
Well, it's I'm gonna say it's a symptom because they're telling you I'm choking through sign language.
So what if they really meant like this? They're wrong.
So
You may have cardiac.
maybe respiratory obtain history of existing. Oh wait, where did it? So, it's I'm not gonna say it's important, but a lot of times you could get a lot of information from the patient by determining whether this has matched previous episode. You're having trouble breathing. Is this have you had this before? Yeah, last year whenever it got cold, whenever it gets cold I can't breathe. Is this any different? No, it's about the same. But sometimes like this one's a lot worse. Okay, and so you know that maybe it's progressed further than it has before, but it does give you an insight to that. This has happened before. This is something that goes along with their disease process versus maybe a new onset. So respiratory assessment, physical examination. So mental status. One of the things that we'll see is a change in mental status, right? Whether it's whenever they become hypoxic, they become anxious initially. What's a sign or what's the definition of shock? Hypoperfusion. Brain's not becoming fused, becoming hypoxic. And so one of the first things that you see is this anxiousness. And we had an instructor in paramedic school, and what he'd always say is, if they can't sit still, that they're squirming and they can't sit still, that they have one of two problems, either in shock or they got to go pee. And so, he kind of always sat with us. Yeah, okay. I'm sure that there's other things too, but one thing that you should suspect is that patient is hypoxic or having hypoperfusion, so they could be going to shock. Level of respiratory distress. Is it something that they're complaining of shortness of breath, but they're sitting there breathing at 20 times a minute, they're 99%. You really don't see it. Or is it something that their level of respiratory distress, that it's acute because they're in a tripod position, they can't catch their breath, they can't talk in complete sentences. Chest wall motion, I'm guessing kind of by this, what they're saying is looking for the expansion and excursion of the chest wall. Is the rhythm regular? So is it a regular rhythmic breath? Is the rate within that normal range between that 10 and 24, which we're determining is serious below and above those numbers. Another thing you could see is sometimes in your traumas, you could see asymmetry in that chest wall motion. So you have one side that goes up, which that could tell you that maybe they have a collapsed lung on one side, or maybe they just are like some patients that are on here that don't even have a lung on that side. And so what you're going to do if you see or notice asymmetry in the chest wall motion is just, you're going to listen and say, hey, I don't hear any breath sounds on the side, or there's something, have you had a lungectomy or anything like that? Oh yeah, I've had this. Oh, okay. And you can go on with your business. Auscultate lung sounds, obviously, you're just listening to breath sounds. And I had you guys listen to the breath sounds on the mannequin. If you don't remember the terms that I gave you as you're listening to breath sounds, you could describe them. The lung sounds sound wet. I hear wheezing in this area. And typically the doctor is going to listen anyway, or they should listen anyway. But you'll at least alert them to listen a little sooner that, hey, these breath sounds aren't clear. Use pulse oximetry. And we talked about some fails that the pulse oximetry has. One, our smoking friends have about a 10 to 15% lower O2 sat because 10 to 15% of that is bound with carbon monoxide. And so we also talked about treat the patient, not the machine. Make sure that machine matches what's really going on with the patient. If it doesn't add up, it's probably not right. And on the opposite side, if it says 100% and they look like they're dying from shortness of breath, it's probably not right. And so don't withhold treatment from them because you're like, oh, you're 100%. Observe edema, and this is important to kind of differential diagnosis. If you have a patient and you go and you check the feed around the abdomen and it has swelling and they're having shortness of breath, we could be dealing with CHF. And that is kind of, you could use that as a differential diagnosis from pneumonia, or you could use fever. You feel their skin and that in the feeling part of your assessment, the palpation part of your assessment, you feel the skin and it's hot. You just breath sounds, you hear what you could describe as wet breath sound. CHF is more of a crackles in the backles. It's like type sound, and I don't know if you guys could hear that or not, but versus a gurgling sound with pneumonia, it just sounds, you're like, whoa, that sounds gross. Just like it sounds like when they're coughing it up, right? But the fever could also help you out with that. Hey, they have a fever. I'm not finding the swelling, so I'm thinking pneumonia versus CHF. A lot of times you could go with other things too. So like history. Do they have a history of CHF? Don't use it as the only thing because they could have had a heart attack a few minutes before. And I have had this patient, a little bitty old lady, and we get there, no history of CHF, and we're like, hey, oh man, what'd you call the ambulance for? Boys, I just can't catch my breath tonight. I'm just not feeling real well. Okay, we're 3 blocks from the hospital. We'll just put you on our cot and we'll take you and get you checked out. It's like warm, pink, and dry, breathing normally. She lives by herself. She's just lonely type thing. Before we got her out to the ambulance, the pulmonary edema was just running out of her mouth. I mean, the peak frothy sputum. So it went from a give this little old, and we didn't mess around with the scene or anything. But it went from give this little old lady a ride and check her out. Sedgwick County, if you don't check them out, you get in big trouble. But we went from this kind of routine, basic call to a very critical call in a matter of seconds. And, that's what had happened is she'd had a heart attack and had complete heart failure. And all of a sudden it just all came out. Backed up on the, I guess it'd be right side of heart failure, backed up, left side of heart failure, right? Backed up into the lungs. And then it's spewing out of her mouth. And so it was a very, I've only had one patient like that. And we called the flash flood. And that's what it was. Anyway, cardiovascular system, heart, blood vessels, cardiac, patient in shock or with vascular problem. So I don't even understand their bullet points here. Something that you guys are able to do as EMT basics is do 12 lead EKGs. I tell every patient that wants me to do a 12 lead EKG on them because they're trying to determine whether they want to go to the hospital with me or not, or they'll come here to the shop and have me do a 12 lead on them. Then one of the first things I tell them is, I just want you to know, and it's usually people's spouses that work for us. Just because it doesn't show up on the 12 lead EKG that you're having a heart attack, doesn't mean you're not. There is a chance that you could be having a cardiac event. So anyway, you guys are able to apply 12 lead EKGs as EMT basics. The only thing is you guys aren't trained or able to read and diagnose off of it. What you guys are able to do is our machines print a machine-generated diagnosis. It's something like it errs in the side of the favor of the patient. It's like 99% accurate. But what you're going to see is if it comes out with some stars and acute MI suspected and some stars, there's a 99% chance that they're having an acute MI and they need, and it's not just an acute MI, it's an ST elevation, myocardial infarction. They call it a STEMI. And STEMIs need to be reperfused right away. They're the quicker lethal cardiac events. They're the ones that need to be reperfused right away to get that perfusion going. So anyway, dang, fire's getting out of hand. So not anymore. Cardiac patient and patient in shock or vascular. Okay. So cardiovascular system history, existing cardiac conditions and medications. You guys will want to become familiar with some basic cardiac medication. Typically, if they have nitro, some sort of blood pressure medicine, there's a good chance they have a cardiac history. So you'll want to kind of become familiar. I would say you'll become familiar with the majority of the drugs in an area are the same. So if a doctor in an area likes writing for something for this type of thing, you're going to see it over and over and over again. Now, if you have a doctor from outside or they go to another doctor, that's when you start seeing other type drugs that other doctors are comfortable with. But you do want to get kind of a base knowledge of what these drugs are. And see if I could give you some ideas. So like if it ends in olol, like labetalol, things like that, it's a somebody's messaging. It's a beta blocker, and what it does is helps control the rhythm, I believe. Don't make me lie. I'm trying to think of some other ones that are like that. Betalol is a big one. But obviously you want to get familiar. You'll get familiar with nitro, aspirin, and some other medications. Signs and symptoms of episode, existing cardiac So we're talking about history. You'll want to find out what the signs would be is for a cardiac event would be cool, pale skin, diaphoresis, and whenever we're talking about diaphoresis, sweating without any real reason. I'm sitting here in my chair watching, maybe not even a game. Maybe they got excited about the game. I was sitting here watching Days of Our Lives and just broke out in a cold sweat. Symptoms are going to be anything on a cardiac for the cardiovascular system, anything from your typical that you know that squeezing pain that radiates into the arm, into the jaw. It could be anything from that, and we talked about the other day, from the feeling of indigestion or doom, or I just don't feel right. I can't put my finger on it. Sometimes you have shortness of breath. I can't catch my breath. You listen, they're clear. You put a pulse ox on 100%. They're not really anxious or anything like that. Maybe a little anxious, but they don't have anything going on that like that would make them anxious. And so it turns out that could be a cardiac event. They call it a silent MI, one that doesn't have that typical signs, and that gets a lot of people. So, description of the chest pain using OPQRST. So I'm having this chest pain. Okay, so when did it start? It started 30 minutes ago. Does anything make it worse? Well, whenever I stand up and I walk to the refrigerator to get another beer, it gets worse. Quality of the pain. What does the pain feel like? Can you describe that pain to me? It feels like an elephant sitting on my chest. Radiate. Does it radiate anywhere? Yeah, it goes down into my arm. And if they kind of look at you funny, does the pain move anywhere? Does it go anywhere? Severity on a scale of 1 to 10, 10 being the most pain you've ever had in your life, 1 being the least. What would you rate it? That's it's probably 6 or 7, somewhere around there. And then time, how long has this been going on? Well, a lot of times with your onset, you could know how long it's been going on. So, what's that? Yeah, there you go. Yeah, exactly. Those are typically at 3 o'clock in the morning. I've had this little cough for 3 weeks now, and at 3 o'clock in the morning, I just can't take it anymore. Oh my God! And you just kind of look at him like, okay, so it couldn't have been bad at 6 o'clock at night, or it had to be bad at 3 o'clock in the morning, in the middle of me sleeping. So, what's that?
The ambulance had went and got that one. They had taken the patient to Great Plains like a few days before, and then they decide, like you said, 3 o'clock in the morning, I just can't live with this discomfort. So
Yep. It's like, why at 3 o'clock in the morning?
this time I want to go to Cheyenne.
Yeah, because Great Plains didn't do anything
They
for
do
me.
nothing. Come here, and the doctor's like, really? Seriously?
Yeah, 3 o'clock in the morning? Yeah, no, it's pretty common, believe it or not. So anyway, determine specific characteristic of pain. So, and we kind of talked about that with the quality. So, my itches. So, look for signs. Condition may be severe. Look for signs. Condition may be severe. Okay. Look for signs. Condition may. I'd like look for signs.
It says including skin color, temperature, condition.
Yeah, I'm just trying to make that sentence work for me. I know it. I think it's a proper sentence. Look for signs, condition.
Just add a that.
I know that's what I'm trying to do. But anyway, so look for. Well, they shouldn't have done that because now I'm mad. Some signs, and we talked about this before on the respiratory. Kind of same thing with cardiac. You'll run into some of those same, or you possibly can. The cyanosis, but we also talked about the cool diaphoresis or sweating, and those type of things. So obtain a blood pressure. Everybody learn how to take a blood pressure, right? Yeah, except for Emilio. That guy has to do it another day. Poor Emilio. So,
Didn't do very
I'll do it Saturday.
all right, that'll work. Are you really gonna come over here Saturday?
I mean, I will. I mean, yeah, I need to do that.
Bring it up.
All right. So, note pulse pressure. Oh crap! Does it tell us what pulse pressure is in there?
What? Oh, yeah.
The
Nope.
difference between,
Oh, yeah.
No, that's it. What's the difference between
Narrowing pulse pressure, the difference between the
the systolic and diastolic?
and diastolic
Okay.
pulse pressure.
Is it also does it talk about mean arterial pressure in there?
No,
Okay.
regular veins.
All right.
may indicate shock, that's all.
So-
it says about the vertical pulse pressure.
So a narrowing of the pulse pressure will look like 120 over 80, 100 over 80. You're narrowing. 90 over 78. You know, it's you had the top number coming down. You know,
Could be the
those
blood
numbers.
pressure
What's
pill
that?
you took.
What's that?
Could be the blood pressure pill you took.
It could be.
That you decided to take as your wife's. And like, yeah, I'll try that. You know, blood pressure's not being very
Yeah.
good. And it goes,
No pulse pressure. Look for jugular vein distension, JVD. Jugular vein distension is exactly what it sounds like. The jugular veins will be sticking out. Some people's jugular veins just stick out. You know, like those guys that don't really have any fat. They're like got these big jugular veins coming down, and then they get mad and their jugular veins are like. So palpate the chest, and then observe posture and breathing. So what are we looking for in the posture and breathing? A lot of times they'll kind of be sitting up, they'll be uncomfortable, and their breathing's going to be a little faster than normal. So, you know, I'm relaxed, sitting back. Yeah, I'm having chest pain, or I'm sitting up. Yeah, oh man, it just hurt. You know, that's two completely different actions that say two completely different things. And so take note of the second one. The first one, you're like, okay, so you're having some chest pain. Okay, a little bit of twirly on you. Mental status, we've already talked about it.
You're on the nervous system.
Nervous system. Great. So, signs of dysfunction of the body. Mental status is always going to be, changes in your mental status are always going to be due to lack of oxygen to the brain for whatever reason it is. So, or disease or drugs. So, right? So signs of dysfunction in the body. So let's say that you have a car wreck, check the nervous system. You do what's called pulse motor sensation. They might have it listed a different thing there. We used to call it neuros intact. It's been different things for different years. But basically what you're doing is checking to make sure that they still have use of their hands and their feet. They could have good pulses. Whenever you have a sign of dysfunction in the body, that's caused by a nervous system problem, you go to check and all of a sudden they don't move their toes. Or like I told you, the lady that shot herself in the chest, whenever she's fighting, I just noticed she wasn't fighting. She's fighting us with her arms, you know, but she wasn't moving her legs through the whole fight. And so I was pretty sure that she went through her spine. And so that's what you're looking for on the nervous system. Neurological assessment history, determine the patient's mental status. How are we doing that? What are you using to determine the patient's mental status? Yeah. So what's the mnemonic that we're using?
Orientated times four.
Okay, that's the A part. That's the A part of it. Ellen has the A part of it.
What'd you say?
Orientated times four.
She has the A part.
Oh.
Poo. So
What?
to determine the patient's mental status, you guys are going to use AVPU, alert, verbal, painful, and unresponsive. Whenever you're talking about alert, we're typically looking at A and O times 3, or alert and oriented times person, place, and time, or A and O times 4, person, place, time, and event. I know that most hospitals use ANO times 4. Most EMS services now use ANO times 4. So anyway, determine the patient's normal state of mental functioning. So you go there and we have, let's say you have a patient with cerebral palsy, doesn't normally not able to talk to you or anything. So are you going to now downgrade this person's alertness? You get there, they're sitting there doing their normal. Is this how he normally is? Yes. Okay. So then they're alert to their normal mental status. Now let's say that same person's, maybe they're not talking to you or they're asleep. Is this how he normally is? No, he's normally awake, looking around. Okay. So now we're going to determine that it's lowered, and we can determine, is it just verbal? Is he painful? Is he unresponsive? If we can elicit in some kind of response from him. So just because maybe their normal isn't normal like for everybody else, you still could check it. Let's say that their eyes are closed or whatever. You still could come up and say their name, Ellen, and she doesn't respond. Do a sternal rub or elicit some kind of pain, and then she responds. Okay, Ellen's, she is painful appropriate. They go painful appropriate and inappropriate. So painful appropriate is they withdraw from the painful stimuli. Painful inappropriate is she squeezes the arm and they move their leg. Yes, that'd be painful inappropriate. So it's not what you normally would see. So we definitely have some kind of neurological deficit there. Obtain a history of neurologic conditions. And so I just use one. Cerebral palsy is one that we have a few patients in the area that have that. We have one that we run a lot. So, you get to know them, you get to know what their normals are. So no, you don't have to ask the caretaker every time, is this how it normally is? You were just here last week. Oh yeah. So note patient speech. Whenever you're doing a neurological assessment, you're going to use, let's say like if you have speech, they have like slurred speech. It could be a stroke. They could have got into something, some sort of chemical they're spraying or something like that. Or they could have just got into some bad drugs. Or some medications they take also. Maybe they took a few too many of their prescribed medications. And or like me, I'll get into my liquor cabinet every once in a while and I get slurred speech. So that is a neurological deficit, right? I should not be operating heavy machinery whenever I can't even talk straight. So anyway, another thing that you're going to use your neurological assessment on, you're able to use it on patients whenever you have like alcohol intoxication, drugs. You're going to check for stroke and different things like that. So your neurological assessment will tell you some things. Physical exams, perform a stroke scale. Here we use the Cincinnati stroke scale, and I'm gonna be completely honest with you. We use a version of the Cincinnati stroke scale. I think the Cincinnati stroke scale in the book is going to be speech. Can't teach an old dog new tricks. Arm drift. Close your eyes and can you hold your arms up? And smile. And so they smile and one side is drooping and the other side, yep, you have one. If you guys, AHA right now is really big into stroke awareness. If driving down I-40, if you see their Think Fast for strokes and things like that, they'll have pictures of people with facial droop on it and things like that. Ellen is doing grip strength right now. That's what I'm saying. We typically do a kind of combination or a version of the Cincinnati pre-hospital stroke scale. A lot of us do grab my hands, okay, squeeze, and then what you end up feeling, say somebody's had a stroke, one side they're able to squeeze pretty good, and the other side they're not squeezing at all. An important thing is if you are going to use arm drift. I've seen way too many people let people keep their eyes open. You got to understand that this person knows there's something going on, that they're probably scared, and people like to deny that they're having a problem. If you deny it long enough, it's going to go away, right? I'm not sick. So you go to do arm drift and you hold their arms out and they're going to try. Now, just because they have a deficit on that side doesn't mean that they can't use that side. And so they're going to keep their arm up. Whereas if you make them close their eyes and then say, okay, I'm going to drop your arms and I want you to hold them out, they can't watch it to compensate for that weakness, and their arm drifts down. They aren't able to feel that as well, and so their arm goes ahead and drifts. So that's just something to think about. Check peripheral sensation and movement. One thing that they had us do whenever I was going through my basic class is don't just have them wiggle their toes and say, "Can you feel me pinching your toes?" Yeah, I can feel you pinching my toes. Okay, have them wiggle their toes, and then you grab a toe. Which toe am I holding? Make them tell you which toe it is. Now, I have steel toe boots on. I'm not going to be able to tell you which toe it is. I don't know. You're holding all of them, I guess. So you'd have to take my boot off. So
Taking boots off is not good.
I showed you the picture of the boot, right?
No, they all.
Oh, can you imagine how that one smelled? Did you ever see the picture? Okay, I'll see if I can find it. It's pretty intense. Yeah, you just don't see this on a normal foot.
Just boots that's going to be taken off a lot of times.
Gently palpate the spine. Whenever you're palpating the spine, you're looking for step off. I'm going to tell you the only time I've ever found step off, and it was just more of a head on crooked than it was step off, was on a dead guy. I mean, his head is like on crooked. He broke his neck. It's obvious. I've had spinal fractures that I've run my hand down their spine, and I can't. I don't know if it's a lack of training. Now, Rebecca and Tyler might be able to feel them because they're chiropractors and they're always playing with people's backs and spines and things like that. But it's not something that I'm good at feeling, and so I don't feel. I'm not able to feel this step off. And so, as you feel down, you might be able to feel a tender spot. But I don't think did I have you checking for step off in the book? Okay, well, deformity. Like I said, the one person that I found deformity in their spinal column, their head was on crooked and their neck was broken. Now then there's the guy that, I don't know that his was broken. No, he hung himself. This one, the one that I'm talking about, was a car wreck. And the firemen are getting ready to do CPR. They're doing CPR. I'm like, no, stop. This guy's dead. Look at his neck. And so, move on. It was a big wreck. Several patients, one ambulance, 4 firefighters, and a lot of patients. And so, they're getting ready to use all our resources on this one guy that you can't save him. Not anymore. You might be able to now. I mean, they're doing these. Have you guys seen that where the kid had the internal decapitation and they were able to reattach and save him? Yeah, they're making leaps. I don't know. It's probably on that Wild and Wacky News or some reputable website like that. So don't quote me if you guys find it. But I was reading it the other day that they're able to attach and they're preparing to do a full head transplant. You guys are looking at me like I'm crazy, aren't you?
I want to watch.
I know, it'd be awesome.
Thinking who's going to volunteer for that?
It's a
2 who's.
okay. So
2 people, isn't it?
let's go. Let's go for 10 more minutes, and I will Google the head transplant while we're taking a break. All right. We'll move on. So yes.
I've got a lot of questions about that.
And we're going to Google it.
Okay.
So we're checking. We're gently palpating the spine for tenderness and deformity. I mean, I guess we find it awesome. Way to go. I'm just telling you the one instance I found deformity in the spine. Wasn't good. Check extremity strength. A lot of times, if you have a spinal injury, maybe it's not a full sever of the spinal cord or whatever, but they become very weak in their legs or things like that. So you have them push against your foot, or like Ellen said, you push against your arms or squeeze. and it's just really weak. And they've been in a car wreck, and they're not 99 years old. Like, ooh, there's something going on here. Be very careful with your spinal precautions. We're getting away from spine boards, but we're still using C-collars. So you want to check extremity strength. That can give you a clue to something that's going on. Check patients' pupils for equality and reactivity. So I've already made it known that pupils are my go-to whenever I'm dealing with certain types of patients. Tells you a lot. So then I get confused whenever I'm like, oh, the pupils are normal and their blood sugar is 80 and they're still unresponsive. I don't get it now. So, endocrine system, the most common endocrine emergency is a diabetic patient. We practice checking blood sugars over here the other night. By all means, if you have a family member, practice checking those blood sugars. I hate being poked with those little things in the finger. I think it hurts. I hate needles. I hate getting poked. I hate getting IVs on me. So, endocrine assessment history, diabetes mellitus, or thyroid disease history. So, hyperthyroidism. The people that looks like they're running Dangerfield, their eyes are bulging out of their head. So, current medications and whether being taken correctly. Diabetics are notorious for being non-compliant. Whether it's because they went to a birthday and there's a cake sitting in front of them and they decided it's a challenge to eat the whole cake, or whatever the reason is, a lot of your diabetics are non-compliant. Your type 2 diabetics. Type 1 diabetics are probably the most compliant people in the world because they've been doing it ever since they're a little bitty, and they know that if they don't do it, they're going to die. So, whether a patient has eaten or exerted energy at an unusual level. So what they're talking about there is, especially on your diabetic patients, if they don't adjust their calorie intake and their insulin, let's say that they decided they're going to go mow the yard and weed eat and stuff, and that's not something they typically do, they're going to burn a whole bunch more energy or sugar, and you might end up with running somebody with a low blood sugar if they didn't adjust and didn't eat properly and things like that. Whether a patient is sick, that will affect their blood sugar. And even patients that don't have diabetes, however you want to say it, even patients that get really sick, like that are septic, they have trouble controlling their sugar levels. So they just burn through the insulin. A lot of times they have like a D5 or some sort of dextrose solution hanging with it. So whether a patient has taken blood glucose or uses an insulin pump, your type 1s will be the ones that have the insulin pump typically. And be careful with those.
They're smart.
Man, they are, and they're getting smarter every stinking year, aren't they?
They said the little girl that's up here that they get a notification if she gets low and she's playing softball, and then they're calling the coach going, you need to have her come up here, you need to do, bring her up here, do this, do that, because they work in
Their cell phones.
yeah, their cell phone.
They have me watch this stuff.
But Mrs. Hayden, she was on her check all the time, and she'll call her up and say,
I gotta try to fix my computer here. I'm gonna lose you guys.
Pull her out, so eats more candy.
There's a little bit of
Do we?
Anyway, they
Do
want
you
me to
see
come up
another
there.
like little
They
extension?
want me to come up there and do some teaching.
Or even
What
more.
am I teaching? She knows everything. I mean, they trained her and she was just diagnosed like beginning
I don't
of school,
get
like
it.
6 weeks before school started. And she didn't show how to see her fingers. She explained, that we gotta look at this little chart to know where, everything. I was like, oh my gosh, what am I doing up here?
Okay, so whether patient is taking. Okay, moving on. I think my computer's getting ready to die, which will suck really bad for us.
You
But
have a charger?
I do, but I don't know what's going on. and this has been doing it with my phone too. It's like blink, blink, blink. It's not constantly charging. Maybe I should try a different plugin. I don't know. I'm gonna try to go on for a minute and then we'll. So evaluate patient's mental status, so endocrine assessment, physical exam, evaluate patient's mental status, observe the patient's skin, obtain a blood glucose level, and look for an insulin pump. So if they do have an insulin pump, I don't know what the basic protocol is for it now. If a paramedic runs one and it's an easy off button, we could turn them off. I don't know what your guys' protocol is as a basic, so make sure you read the book. Yeah, you got to find one first. But they are, you guys were right. They are getting a lot better. A lot of them now, they do a constant monitoring of the blood sugar. They'll shut off if the blood sugar starts to get low themselves. So, the GI system, gastrointestinal system, look for what goes in, food, what comes out, and what it looks like when it comes out. What the? There has to be more than that. I told you. There's a reason we don't listen to bowel sounds because we just. This is the extent. This is the extent that we're going through here. Something that is important is if a patient has diarrhea, that could throw off their electrolytes fairly quickly. So you want to make sure that you figure out how long this has been going on. You'll be amazed. You'll be like, how long is this going on? 2 weeks. What? Why are you just now calling the ambulance? And no wonder you're confused. So on the history and assessment, you want to do, oral intake. So what have you eaten? Well, you're eating 16 tacos a day. Please stop eating 16 tacos a day. Pain, gastrointestinal issues, vomiting, and then bowel movements. Have you had a bowel movement today? No, I haven't had one in 36 hours. You can bet if they're elderly and they haven't had one in 24 hours, they're doing something about it. So they're not going through. They're gonna go down and buy some sort of laxative or fiber or whatever.
We do it at the age of 10 years old.
Do what?
So at the age of 10, I got one that I have to.
Oh, do you?
Just because his stomach is crazy.
We had with ours for a little bit. We had to worry about it because he didn't drink enough water. I think was his problem.
I'm drinking a ton. He just has bad stomach issues. Period.
That used to be the number one thing. When I first got my CNA, I was so embarrassed to ask. I was so embarrassing. It's like,
The nursing industry really likes talking about people's poop and pee
And looking at it.
and looking
I
at it.
like to look at it. Oh, gosh. You can learn a lot from looking at it.
look at it,
You-
dig in it.
Oh, come on.
Like it.
Okay, let's take a break. Let me try to figure out this computer issue. Why it's not charging.
My parents go crazy.
I ask my kids every day, feel about today?
They forget like, I don't listen to
I ask my kids every
No,
day.
you can plug it into the side of my computer.
I took my square. Oh, I have a square.
I've got another.
It's freezing in here.
Oh, that's it.
Yes, it is.
All right, I need to find another. You got another. Yes.
Supposedly the head transplant is supposed to come around till December of this year. There's some guy in Russia that volunteered to donate his head for the very first head transplant,
When's that supposed to happen?
December of this year.
Yeah, see?
But this right here is showing how they're gonna do it.